Welcome to another episode of our Innovations in Hematology and Infectious Diseases from Fortis Institute of Blood Disorder and Center of Excellence for Infectious Disease Disorders, led by Dr. Neha. It's my pride and privilege to introduce Dr. Abhay today, who will be speaking on a very, very important topic on antimicrobial stewardship in immunocompromised patients. And one thing Dr. Neha has brought on table is that holding the hands of the clinician and taking out the 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 fear out of their mind, saying we will take care of it and your patient is not going to die. Because as a hematologist, when we are trained to escalate drugs. One, meropenem, then targocet, and then colistin, and then zevicefta, astronam, and so on and so forth, on the basis of patterns of either culture coming positive or 2 days of fever, 3 days of fever, 104 temperature, patient not responding. Oh, look, patient is transplant. So antimicrobial stewardship does not hold true to us. But what Dr. Neha has brought in on the table for all of us in past 3 years is that comfort and taking the fear out of our minds, because now we can rely on Dr. Neha to take the calls. And we are, touch wood, we have not lost a patient because of not escalating the medications because of fear and not because of science. So with this, thank you, Dr. Abhay. People across 35 countries will be happy to listen to you and learn and use their practices, use your learning into their clinical practices. Technically, 200 to 250 people tends to join from Iraq to Africa to Myanmar and Bangladesh. Thank you once again, and I welcome to listen to your thoughts on how we can make policy changes into our immunocompromised patients for better and healthier future, safeguarding the future antibiotics for the future pandemics to come by. Over to Dr. Neha.
Hello? Am I audible?
Yes, ma'am.
Right. Yes, Neha, you are audible.
Yeah. So thank you, Rahul sir, for that introduction. And just setting the next context, as we know that this is a World Antimicrobial Awareness Week going on. And as we say, the AMR is one of the biggest challenge we all face together, irrespective of the immunocompromised. But of course, it becomes a double trouble when there is an immunocompromised population. Talking ahead, we have Dr. Abhay Dhan, who, although needs no introduction, he is one of the very famous ID stalwarts we look forward to listen to. Sir, first of all, proudly to say that he is an AIMS alumni, and then followed by he did his transplant infectious disease fellowship, and then now he is a director at transplant infectious diseases at Westchester University in New York. Without wasting a further ado, sir has done a remarkable jobs in the antimicrobial stewardship, antimicrobial resistance in the solid organ transplants, as well as the HSCT. So moving on, I hereby welcome you, Abhay sir, and looking forward to learn a lot of you about the AMR. Here, over to you, Abhay sir.
All right, thank you very much, Neha. Thank you for inviting me. And hello, everybody. Let me just start sharing my screen. All right, just want to make sure that you guys can see it, right?
Yes, sir, we can see.
Okay, all right. So thank you again for inviting me. And hello, everybody. My name is Abhay Dhan. I'm one of the infectious disease physicians. I work in New York. And just quickly, my journey started at AIMS 1992. I did my infectious diseases fellowship in Boston in Tufts. And I have been working as an infectious disease attending. And then I was able to set up the transplant infectious diseases program. And along with that, I helped run the quality for the entire transplant program also. So I look forward to sharing some of our experiences in antibiotic stewardship. And I'm going to try and breeze through some of the talk. The main purpose would be some of the introduction, to give you just an introduction, and then kind of take you through some of the local challenges that we had and how did we use the power of antimicrobial stewardship to address those issues. All right, so let's start with the antibiotic. Penicillin was the first antibiotic that was put into modern medicine, and we know the power of antibiotics. They save lives, and this what started in World War II when penicillin was invented, and the power of antibiotics was seen with the soldiers that were getting injured in World War II. They were successfully treated for their wound infections. But with that, that is where Alexander Fleming came with the warning that anytime you have an antibiotic, microbes can develop the power to develop resistance to these antibiotics. And the key is to use these antibiotics in a thoughtful way. A thoughtless person who's playing with penicillin, it's morally responsible for the death of the person who finally succumbs to the infection with penicillin. So I think these are very words that are still important, even though we have grown and we see a lot of new antibiotics. But the problem, the challenge of utilizing the antibiotics appropriately remains same as it was in World War II with the discovery of penicillin. So this is where we are right now. This is the per capita antimicrobial resistance all across the world. I mean, clearly a lot of gray zones where there is no data available. So wherever the data is available, you can clearly see the hotspots all around the world where the emergence of antibiotic resistance is being seen, and the prevalence is extremely high across the continent. Now, all of the people in the audience know the number one cause of antibiotic resistance is utilization of antibiotics. Now, the key to utilization is appropriate utilization. Whenever we have inappropriate utilization of antibiotics, bacteria develop resistance, and that is where we see the spread of antimicrobial resistance. So coming to antimicrobial stewardship, who is a steward? So this comes from an old English language, that is the person, the ward who protects the house. So that is the role of an antibiotic steward, whoever person who takes on the responsibility of antibiotic stewardship is to protect the antibiotics, protect the patients, and to protect the antibiotic for the future use. So why do we use antibiotics? The heavy use of antibiotics is driven by a lot of stuff. And I think something that was just mentioned before, the main driver is fear. And that fear is multiple times enhanced when you're taking care of an immunocompromised person or a severely ill person. And when we are taking care of immunocompromised people, not only there is a whole component that they are severely ill, they are immunocompetent, they do have breaches of the natural barriers because of various catheters and stuff, or severe mucositis that they develop after the chemotherapy. So the risk of developing infections is multiple fold. But then the utilization of antibiotics is extremely high, mainly driven by the fear of missing a life-threatening infection. That is further confounded by diagnostic uncertainty, lack of knowledge, unavailability of ID specialists, not having proper guidelines, and some little functional reserve in the patient. So selection pressure, broad spectrum antibiotics, overutilization drives antibiotic resistance. So how do we counter the fear of missing out on things that leads to overuse of antibiotics? So this is what I have learned in my experience. While antibiotics do protect life and they save lives, antibiotics are also very potent psychoactive agents because they act on the prescribers rather than the patients. When providers are afraid, they act instinctively, and the antibiotics soothe their fears. Also, antibiotics are treatment for insomnia for the providers, because it basically helps us sleep better at night because we think we are doing something. But there is a downside to using antibiotics. So the question becomes, how can we overcome this fear? So this is where we come in. I think it is. I'm very happy to see the emerging field of infectious disease in India. Clearly, that is the need of the hour, especially when you see in India developing as a hotspot for emergence of antimicrobial resistance. So having an ID specialist and an ID consult available, just like you have in your hospital, is one of the keys in which you can soothe the fears of the providers that they are available and they will provide the right care and the right, they'll give the right counsel to the patient for taking care of them. Education is the key, developing a differential diagnosis. And the power of diagnostic, this is where the rapid diagnostic that are increasingly being developed all over the world. Now, utilization, availability and utilization vary from place to place and type of hospital. So the methodologies that you develop to cope with this stuff can vary from hospital to hospital. Also, we have biomarkers that are developing that can help distinguish infection versus non-infection. Also, they can help predict the severity of infection or a response to antibiotic treatment. And you can utilize the combination of these things to help make the right decision. Something that we're focusing on is catching them young. So we do develop a lot of education that is geared towards medical students. Um, and in my experience, a lot of these things, the dogmas for treatment of antibiotics and the duration of antibiotics, they come without any data. It's basically if something was taught to my teacher by their teacher who were taught to their teacher, just basically keeps on getting handed over from person to person, and that kind of becomes the standard of care. And what we are trying to do is catch these medical students very early before they develop this dogmas of treatment of 1 week, 2 weeks, 3 weeks, IV antibiotics, oral antibiotics, and try and justify why and how we use antibiotics. And then develop accountable justification. Use antibiotics, but you should have a justification of which antibiotic, how to use it, how long to use it. And this is where the role of antibiotic stewardship comes in, because then you hold the providers accountable for utilization of antibiotics. By reviewing the antibiotics, you can give them feedback. And by all of this stuff, ultimately what you're trying to do, which looks like you are ahead of the curve in there, is to develop the trust. The most important component of a strong antimicrobial stewardship, where you read the right utilization of antibiotic, is the trust between the infectious disease provider and the team that is taking care of the patient. And in this case, we'll be talking about the oncologist and the transplant physicians. So ultimately, we got to fight for the right. And what is the right? The right to use antibiotics. Not only that, we have to use the right antibiotics at the right dose for the right patient and for the right duration. And that basically summarizes what an antimicrobial stewardship is. Antimicrobial stewardship was defined a few years ago, around 10 years ago, by CDC. And these are the core elements that were developed, in which you need to have an accountability, a single leader that is responsible to run the program, develop the program, run the program, and is accountable for the outcomes. You need to have a person who has the expertise. It can be an ID physician or an ID pharmacist who has the working knowledge that can be implemented in the hospital. And then with that, you need to develop some actions that are driven by the local challenges. And while you're doing that, you need to have a process of tracking what you are doing. Mainly, it is looking at the antimicrobial antibiotic prescribing patterns, resistance patterns, and looking at the trends over a period of time to see if your interventions might be working. You need to have a structure to report the data to all the people who are involved in the process on a periodic basis. That includes physicians, nurses, and all the relevant staff. And education, again, is a key component. So now, building on these core elements, I'm going to talk about what we did in our hospital. So we set up the antimicrobial stewardship, which was basically run under the umbrella of Antimicrobial Stewardship Quality Council. And our antimicrobial stewardship was run by antimicrobial stewardship physicians and ID pharmacists, and with the support of nursing, clinical microbiology, information technology, hospital administration, ID physicians, and infection prevention and control. And ultimately, we reported to the board of the hospital, so in which we were able to capture the institutional priority of antimicrobial stewardship, so we can get the right resources to continue building on the processes. So started a little bit by antimicrobial approval process. We do have a list of antibiotics that we think require protection. These are the antibiotics, either they are expensive or they are targeting niche organisms that would be resistant organisms, or these antibiotics or antimicrobials have a very narrow index for toxicity. So you want to make sure that you minimize the harm. So anytime a provider is using any of these antibiotics that are on the restricted or the protected list, that requires an approval. And for us, that approval is a mini ID consultation, because it becomes a point of care in which you can kind of help the providers and teach the providers, do you really need to use the antibiotics? Make sure you screen and triage the right antibiotic, the dosage, make sure they send the right tests, and if required, escalate it up to getting an ID consult. This is followed by doing a daily audit with intervention and feedback, in which we review the antimicrobials on the protected list to try and make sure we realize their ongoing utilization, review the cultured results or toxicity data or therapeutic drug monitoring to make sure the drug is being used appropriately. What antimicrobial stewardship is not, it is not an ID consult. It does not replace an ID consult. So what we try to do under the umbrella of antimicrobial stewardship is to support the ID team and the other providers and make sure everything flows in the right direction, and cumulatively we do the right thing for the patient. So this is where we started. I started the program under the CDC milestones in 2014, and we put, these were the broad categories that we were looking at, and we tried to develop this. Now, this was for the whole hospital, including targeted at immunocompromised patient as well. So we picked the categories of looking at infection syndromes, designing specific interventions for those infections or syndromes. Plus, we had pharmacy-driven interventions. We looked at the outcome measures. We looked at the tracking and reporting of antibiotic utilization. Broad interventions, that was the minimum basic of authorization of these restricted antibiotics and feedback. And then we developed the education component of that. So we were able to develop treatment guidelines and bundles for the following syndromes. We developed a treatment bundle for the most common infections: Staph aureus bacteremia, Candida bloodstream infection, gram-negative bacteremia, that included picking the right antibiotic and the right duration of therapy, C. difficile infection, urinary tract infections, and MDROs. Now, this was based on, we targeted these things because these were the problems that we identified in our institution, where the risk of people dying from these infections, risk of having a bad outcome, or risk of having readmission was extremely high in this group. Now, this was across all patients, but there was a huge focus based on the Candidas and the gram-negative C. diff infections and the MDROs on the immunocompromised patients as well. So where do you start? The start is picking an antibiotic. And what we realized, the most important part of picking the antibiotic was the role of antibiotic allergy. And once the patient gets labeled as an antibiotic allergy, it minimizes or restricts the antibiotic choices. So we started by developing an allergy assessment protocol that all the providers had to go through before they picked an alternate antibiotic or reason not to pick the antibiotic. So we developed this pathway, which is available through our EMR, and it is an educational tool. So people, the providers, I mean, we are a teaching hospital as well. So all the teaching hospital, the trainees can go through the steps to do a proper allergy assessment. And based on the allergy assessment, we had guidance to which antibiotics to pick and which antibiotics to avoid. So that was the first step. And next step for us was to review the local epidemiology. And our huge focus was on MDROs. And I'm going to talk about some of the things that we did. So empiric therapy, when you're picking for the patient, we had to develop the guidelines to pick an empiric therapy for all the infections or syndromes of interest. So we utilized all these tools. We looked at the epidemiology and utilized the combination of prior culture results, the environmental pressure, recent antibiotic use, and the role of biograms to try and decide what the empiric therapy for that individual patient might be. So I'm going to lead you to some of our data. What we saw, the trend overall in our institution over a period of time was that we had an increase in ESBL isolates. Now, this was based on the phenotypic testing. The ESBL production was going on. And what we realized was that not all ESBL infections are the same. And what we realized was we were two parallel things going on. We had an increase in ESBL producing E. coli, as you see in this graph over here, that went from 2015 to 2018 and almost tripled. On the other side, we had the ESBL in the Klebsiella, which had decreased. So the rate decreased significantly, and that includes carbapenem-resistant Klebsiella as well. So that made us dig a little bit deeper as to what the mechanism of that. So we were able to do whole genomic sequence on these isolates, including the historic isolates and the current isolates. And this is the data from 2005 to 2017. And what you're looking at is the mechanisms that mediate ESBL, the extended spectrum beta-lactamase mechanism in these organisms. And these are the three common organisms. You have SHV, TEM, and CTXM. And what you see is clearly a trend. Not only the ESBL E. coli were going up, Klebsiellas were going up. And what you see here is the mechanism mediated through the CTXM gene was going up. Now, what is the relevance of that is it helps you pick not ESBLs are the same, and the mechanism between E. coli and the Klebsiellas and the presence or the absence of gene is slightly different. So we utilize this information, we utilize the genotypic information, and then we went on to look at are all antibiotics the same regardless of the site? So we looked at all our E. coli and Klebsiellas going back at the same thing to decide which is the right antibiotic to pick for empiric therapy. And what you see here is if the organism is coming from the urine source or an unknown source into the bloodstream, the first line antibiotics that we use, cefepime or zosyn, the antibiotic susceptibility is very different. So that also helped us decide what the source of the of the organism or the infection might be to try and pick the right antibiotic. Along with that, which I'm not showing you the data, which is exactly what you guys are doing as well, we based it out. We looked at the infections, the organisms in various units of our hospital. And what we realized at that time, now these were the days before we had the newer testing, the genotypic testing available, the probability of an E. coli in our oncology patients of being an ESBL organism was 70%. It was a Klebsiella, the probability was 30%. So same thing we were able to utilize to try and see what is the pretest probability of picking the right empiric therapy for the patient. This is something, again, you guys are aware of. Do hospital antibiograms help predict? And the answer is no. You cannot use a hospital-wide antibiogram to target extremely high-risk immunocompromised patients who might and might not have been exposed to antibiotics, or they colonized with different multiple resistant organisms in the past. And when you look at the most common gram-negative organisms here, E. coli and Klebsiella, this is pooled data from a large network of veteran administration hospitals. These are the people who have who are veterans from the army or military, and this is a single center where, and they pool all their data, and this is what you look at. The susceptibility and the specificity for E. coli and Klebsiella, just looking at a hospital-wide antibiogram is not very good. Same thing in solid organ transplant. Now, if you look at all patients in one institution, this is the data from one institution, and you look at combined solid organ transplant, and then you break it down by lung, heart, liver, and kidney transplant, you see the resistance patterns that you see in these patients who come from different subgroup of immunocompromised patients can be slightly different. So just using one hospital-wide empiric therapy is not the right thing to do, and you have to target the right patient with the right empiric therapy. Now that was just building the treatment pathways implementation for picking the empiric therapy. The next thing was to pick the definitive therapy, and I'm going to spend a little more time because this is where we targeted the MDRO therapy. Now, definitive therapy is based on organism or syndrome and syndrome based. We have planned for de-escalation of therapy, which route of therapy to use, and what is the right duration of therapy. So forgive me, some of these things might be a little small. I'm not sure how well they are projecting, but these are the treatment pathways that we were. So the problem we were addressing was increase in the carbapenem resistance. And That was driven mainly by use of carbapenem for treatment of every single ESBL infection. It didn't matter what the organism was, it didn't matter where the infection might be. Every single person was getting treated with the carbapenem. And the problem was twofold. One, it increased the carbapenem resistance. Second, people were getting hospitalized because, at least in US, till very recently, we didn't have any oral carbapenem available. So this required patients to getting hospitalized. So what we did with the previous data that I shared with you was we built an treatment algorithm for treatment of ESBL organisms based on what is the organism and where is the infection. And this also required looking at the literature, what is the current standard of care. And we built that stuff in 2017. And what we showed was if the infection was in the blood, clearly carbapenem therapy was the standard of care. But along with that, we built a stuff to make sure for each bacteremia, we identify the source. If the source is identified, do a source control. We required an ID consult. We came up with the duration of therapy, when possible, switch to oral therapy, and then identify the patients to prevent reoccurrence of the same event. Now, that is not true for a non-bacteremic patient. So if you have infection only in the urine, asymptomatic bacteriuria, no treatment, cystitis can be treated with short course with an oral antibiotic. But if you do have a complicated infection, with that, we built in either the organism was E. coli or the piptazo-MIC was less than 4, that would be zosyn. Then we used a non-carbapenem therapy of piptazo. So this was under the umbrella of carbapenem sparing therapy. Moving on to the next syndrome of intra-abdominal infection, in which again, the first thing was to identify the source for intra-abdominal infection, do source control, and then try and do a non-carbapenem therapy for these patients with the goal to prevent carbapenem resistance. And in these people, we did non-carbapenem, non-daptomycin therapy. Daptomycin is the therapy of choice for VRE, which is a problem in our institution. So this is where we instituted eravacycline as a non-carbapenem therapy. Moving on to the carbapenem enterobacteriaceae, again, the same concept. If the infection is in the blood, we use the genotypic testing. For us, predominant carbapenem resistance in gram-negatives is driven by KPC gene. Our first-line therapy is meropenem verbactam, followed by these organisms. If KPC is not detected, that's where the mechanism is non-KPC mediated. That's usually OXA48 or other mechanism. That is where meropenem verbactam does not work. Our standard of care was ceftazidime avibactam. So here what we're trying to do is, again, individualize the care for the patient based on all the data that is available. What is the organism? What is the resistant gene, at least in the genotypic pattern early enough? What is the site of infection? Same thing that you see in non-bacteremic patients, complicated UTI versus an uncomplicated UTI. And same thing for intra-abdominal or wound infections. So we have a non-blood, non-urine infection. For us, the treatment of choice was eravacycline. And again, the goal is not to utilize one antibiotic exclusively that's going to drive antibiotic resistance in that patient, in that particular unit, in the cumulative immunocompromised patient population in our hospital. Slightly different for carbapenem-resistant Pseudomonas, where again, the treatment of choice for us would be ceftolozane tazobactam, because we're trying to preserve ceftazidime avibactam, cefderichol, imipenem relebactam for carbapenem-resistant enterobacteriaceae infection. But the goal for all these things is to make sure we identify the source and do the source control. And that is important because that helps decide the duration of therapy. As long as the source is identified and the source is taken care of, that becomes the target of short duration of antibiotic therapy. So again, that you see the treatment is driven by the organism, the site of infection, and that helps target. VRE is a huge problem for us. Again, targeting what the site of infection is. We have treatment algorithms for treatment of blood infection, bloodstream infections, urine. We do not treat VRE in the respiratory tract, intra-abdominal infections. Either it's a polymicrobial infection with the permutation combination of ESBL gram-negatives, susceptible enterococcus, regular gram-negative with VRE, ESBL with VRE. We do the carbapenem sparing and the daptomycin sparing therapy using eravacycline. Again, this is a specific challenge for neutropenic patients. And this is a newer article that just got published last year. And they talk about what are the possible targets that you would be looking for. And some of these things I'm going to share a little bit of our experience as well. So most of this thing is picking the empiric therapy, and I talked about there is definitely a role of screening the patients. It all depends how much resources are available and how intensively you can screen the patients. We utilize the prior history of being colonized with an organism as picking the right empiric therapy. And then these are all the other interventions that can be done um, depending on what is available. And if rapid antimicrobial susceptibility is available, that should be utilized heavily to try and pick the right definitive therapy for the patients. And then picking the right empiric therapy, moving on to the definitive therapy, have developing facility specific guidelines, some of that stuff that I showed you already. And the other important thing that we talk about is the role of monotherapy versus the combination therapy. And there's enough data now to show that when for definitive therapy, monotherapy, as long as you have the source control, monotherapy is as good as a combination therapy with some caveats here and there. But for predominantly monotherapy should be good enough. Make sure we're giving the right dosage for the patients. If indicated, use prolonged infusions. When available, use therapeutic drug monitoring to make sure that the antibiotic dosing is appropriate. And then moving on to the duration. What is the right duration for antibiotics? And when possible, can you de-escalate the antibiotic? De-escalate to a narrower spectrum of antibiotics and de-escalate from intravenous to oral antibiotics to help preserve the antibiotic utilization. So moving on to the question, does duration matter? Now, duration again is a dogma that's somehow came into the modern medicine. And this is, those of you who follow antimicrobial stewardship, we are all followers of Dr. Brad Spellberg. And he started this few years ago where he started defining the shorter therapy compared to the conventional therapy that was taught to us. And somehow the whole therapy is done in intervals of 7 days. I guess it makes us feel better. We do 7 days, 7 to 10 days, 10 to 14 days, 14 to 21 days of therapy. And when you look back at it, there is absolutely no evidence for doing this therapy. What is the evidence now? This is the evidence for a selected number of patients, including immunocompromised patients. Shorter therapy is as good as longer duration of therapy. Why can it be better? It can be better because with each therapy, you're taking the risks and the benefits. The benefits of the therapy are clear, but the risks of having a side effect or a long-term emergence of antibiotic resistance are not readily apparent right away. So cumulatively, if you use a less shorter duration of antibiotic therapy, it might be beneficial in the long run. Now, these are the different syndromes for there's clear-cut data where a shorter duration of therapy is as good as a longer duration of therapy. Talking about immunocompromised patients and bacteremia and neutropenic fevers, in my training, we were taught once you start for treating the neutropenic fever, you continue the same therapy till the neutropenia resolves. And that clearly has been debunked. Once the patient gets better, ANC is improving, you can stop the therapy and de-escalate the therapy. Gram-negative bacteremia, as long as the source is identified, source is taken care of, 7 days is as good as 10 to 14 days of therapy. And of course, our immunocompromised patients do get regular infections like community-acquired pneumonia, ventilator-associated pneumonia, or UTIs. And this is a cumulative thing which tells you necessarily more is not better. And for some of the patients, shorter can be better. So that led us to develop antimicrobial stewardship targeted specifically towards transplant patients. And we took the lessons learned from our hospital to target the transplant antimicrobial stewardship. I'm going to talk some, and this is what I've highlighted is again the problems that we encountered in our institution. Antibiotic allergy assessment is true for all the patients. So we made sure that the antibiotic allergy is done and documented properly at each step of evaluation of transplantation, from pre-transplant evaluation to the time of hospitalization to picking the right perioperative antibiotics and later. Pneumocystis prophylaxis for us again is very important, but we've realized we are transplanting older and older patients with the risk of delayed strep pneumo infection or delayed pneumocystis infection is true. So we want to make sure we develop the sulfa allergy assessment based on the beta-lactam allergy assessment. And we built a tool for oral escalation therapy for transplant patients with the goal that they get all who patients require sulfa therapy, Bactrim therapy, they should get the sulfa therapy for prophylaxis. Recurrent C. diff infection was a huge concern in subset of our patients. That was in our liver transplant and heart transplant patients. So we developed certain projects I'm going to share with you for recurrent C. diff infection. Duration of therapy was picked right from the general antibiotic stewardship things. Perioperative antibiotics, we developed a targeted antibiotic prophylaxis for liver transplant. As compared to in India, most of our transplant are deceased donor transplant. And unfortunately, things that we've noticed in COVID, now we're transplanting people with alcoholic liver disease, fulminant liver disease from alcohol, younger people, majority females. They come to the hospital extremely sick. Basically, it's their terminal hospitalization. Either they die or they get transplanted. This is compared to very different other set of people with chronic liver disease who deteriorate over a period of time. So these people are in the ICU, they're bleeding, they get a lot of antibiotics. They're in our hospital, they're colonized with VREs or ESBL organisms, risk of C. diff infection, breakthrough infection, breakthrough gram-negative infections, and candida infections extremely high post-liver transplant. So we develop a targeted perioperative prophylaxis for those patients. Another thing about the opioid epidemic going on in US is a lot of donors dying from drug overdose. They also have concurrent hep C infection. So we utilize taking the hep C positive organs for our patients. And we realized that the therapy for these patients can be 12 weeks, which can be extremely expensive. So we developed a shorter duration therapy that can be given perioperative to try and decrease the burden. We also developed CMV prophylaxis and treatment, antifungal stewardship, and a whole bunch of other stuff. So I'm going to do, for the sake of time, I'm going to talk about 2 or 3 things that we have seen some positive effects with. So I think, just to summarize, when you are developing an antimicrobial stewardship, whatever other hospitals are doing might not work for you. You have to identify the local challenge, and you cannot really win every single battle. So you have to try and find the thing that gives you the maximum benefit with the amount of work that you are able to do. And this is developing the solutions targeted towards the local challenges. And more importantly, look at those outcomes to make sure what is working and what is not working, and share that with the teams, because this is where the trust building happens. I'm going to share this, our experience of Enterococcus. Our main organism was driven by BMT population and liver transplant population. We saw Enterococcus, this is mainly Enterococcus faecium, VRE, vanco-resistant Enterococcus faecium, go up exponentially in our hospital. Daptomycin became available in 2009, and that became the standard of care or the treatment of choice for our patients. We utilized enough daptomycin. In 2014, we saw, this was our utilization of antibiotics, we saw a very high rate of daptomycin resistance. 12% of our isolates were resistant to daptomycin. We were able to do genotypic analysis again on these patients, and we saw emergence of a new sequence type, which was called ST736, which was associated with daptomycin resistance. So it's time for us to do something. Same thing, you're looking at we compared to the historic isolates from 94, 95, 2009 to 2012, and 2013 to 14, you see emergence of ST736, which was associated with daptomycin resistance. So this is something that we developed. This is a set of interventions. We put daptomycin on the protected list. We were reviewing it every single day. We made sure we did antibiotic allergy, so people are not getting switched to daptomycin when the alternative therapy is available. Discontinued for Enterococcus in the urine, came up with the alternative therapy for intra-abdominal infection, the protocol that I shared with you before source control, cut down on the duration of bacteremia, especially neutropenic patients where they do not require, we realize they don't necessarily require a prolonged antibiotic therapy, especially in the setting of mucositis where you suspect they might have transient translocation of the bacteremia. You do not need to give extended courses of daptomycin, optimize the dose, and we looked at the other risk factors to cut down the risk of developing infection to begin with. Now, this is what we saw. We implemented the pathway. Within 4 years, the daptomycin utilization, this is days of therapy, went down more than 50%. And what happened? The rate of daptomycin resistance decreased from 12% to 4%. Not only that, it led to change in the genotype around the hospital, where it went from ST736 to ST117 as the predominant isolate. So antimicrobial stewardship is a direct result of in developing targeted interventions to see how it works, and these are the outcomes for that. I'm going to talk one more thing about Clostridium difficile infection. We developed a pathway to try and see how to prevent C. diff infection. This is prevention of the recurrent episode. So we set up a real-time alert for, we were reviewing real-time alert from the microbiology lab for any blood cultures, for any organisms of interest, the MDROs, and a C. diff result. We had the same thing going on for the multiplex PCR results that are available for the respiratory tract or the urine or the CSF. We were getting real-time results, so we can act on those results. So this was on the basis of the patient had C. diff infection. We built a bundle to make sure, can we stop the antibiotics? Patients with previous history of CDI, to make sure they don't get clindamycin or fluoroquinolone, stop the PPI, minimize the length of stay. And then we looked at the risk factors for recurrent C. diff. Are they modifiable, non-modifiable? Some of them, these fall into the modifiable risk factors. Now, some patients who had non-modifiable, more than 3 non-modifiable risk factors, that pretty much includes all immunocompromised patients because they are immunocompromised state, more than 60, they're on PPI, they have chronic renal disease, they have ongoing antibiotic use, they need to stay in the hospital. Those are the people we target for adjunctive therapy. And in our solid organ transplant and bone marrow transplant, we utilize bezlotaxumab, which is the monoclonal antibody against toxin B. And what we showed was in our high-risk solid organ transplant, not only it was safe and tolerable, the rate of recurrent C. diff went from 25 to 40% to less than 5%. Now that was very important for us. It decreased the length of stay, it decreases readmissions to the hospital, decreased the impact on the graft. This is something we just developed few months ago. CMV stewardship, again driven by our problems, where we're seeing severe, persistent, prolonged neutropenia in our liver transplant and heart transplant patients. We're also seeing late CMV patients after stopping the primary prophylaxis, as well as we're seeing resistant CMV. So now we have newer antiviral therapies. So we just wanted to see how to utilize that. We have quantitation of CMV immunity, specific immunity. We want to utilize that to make the individualized care for that particular patient. So we were able to utilize all these things to develop a personalized therapy for primary prophylaxis. That's the duration, which therapy to use, what dose to use, and how long to use that. For treatment, which treatment to use, how long, do the patients require secondary prophylaxis or not? Just a quick word on the donor-derived hep C infection. We implemented a pathway, 7-dose ultra-short treatment using sofosbuvir, velpatasvir. It's a pan-genotypic therapy. We know the pharmacokinetics. So this is, I have not updated. This is something that we had presented in the last meeting. This was our first set of kidney transplant patients where the donors had hep C positive, and this is the conventional therapy. You see the duration of therapy went down basically from 7-dose therapy. They got it while they were in the hospital compared to the 12-week therapy that the patients got after they left the hospital. And what we showed here was they estimated all the patients got cured. They cured, the infection did not reoccur in any of these patients. But look at the cost. So the cost went down to less than 3% of the hep C therapy. So that was a net cost. Not only was safe therapy, efficacious therapy, it basically increased the donor pool. We were able to safely utilize organs from the donors with Hep C infection, we decrease the cost to the healthcare as well. So just to summarize, I mean, this is something we talk about. Whatever we have learned over the period of years, we have to be willing to evaluate every single time as new data comes, unlearn what we have learned, and then we have to start learning all over again. With this, I'm going to stop. I think I might have exceeded the time. So much to talk about. And let's see what you guys have to say.
Well, thank you so much, Abhay sir. That was amazing. And as you said, that the topic is so fast, we all know, and it's just like an ongoing process. And I'm just for a disclaimer, I'm gonna steal your one line, which made my day. That is that the antibiotics are actually the treatment of our insomnia. That made me something very, very, very relatable, to be very honest. So thank you so much, sir, for that wonderful, wonderful talk, and made us realize to the different aspects of empiric to definitive, and especially the shorter is the better. And as you have rightly said, and we are now started following, of course, coming out of step out of that fear and eminence to more evidence-based medicine. So just in the paucity of time, I'm going to take 5 6 questions very quickly, which are very, very troubling, to be very honest with us. And so first thing to talk about certain screening protocols, because many a times when we take up the patients for the different kind of transplants, two important things to always being considered, especially in the MDRO settings, is how much is the relevance of the surveillance cultures, especially the stool samples or the nasal swabs, in order to guide the treatment-driven strategy, A, for the patient, B, for the rest of the patients in the unit.
So I think that is a very important strategy. And I think it is more important for picking the definitive therapy or the empiric therapy that would be targeted for that patient. Now, would you just screen that alone? I mean, I think we tried to build an algorithm and we ran into trouble because one, it was very cumbersome. Second, we ran into a brick wall with our infection control because they did not want to know what the person was colonized with, because that meant they had to do a lot of extra procedures for that stuff. But there is a lot of data that shows the risk of developing invasive infection is basically what you colonize, especially talking about the neutropenic patients, is what you colonize in your gut with. So there is a definitive need for that. We started doing that. We do it in targeted patients, mainly to see people who have been colonized in the past. We know they're colonized, to see have they cleared their colonization. So we kind of were able to finagle that thing in our hospital. But our protocol that we had developed to look for hospital transmission as well was not only to screen the patients, but to screen the environment as well. So we were screening, our funding for the genomic analysis ended during the COVID time. So all the data that we had compiled, we were not able to do it. We're trying to get a grant, but basically we're doing environmental sampling, sampling the patient, sampling the bathroom, the doorknob, and other things to see where the transmission might be going on. And not only that, look for transmission from inpatient to the outpatient thing also. So I think that is important for the transmission purposes. And we were working, we do also have an algorithm. It's not commercialized yet, is looking at, can you predict an hospital outbreak by doing genomic analysis on every single culture result? It doesn't have to be patient culture, any culture result that comes into the hospital to prevent outbreaks from happening. But to design a personalized care for that patient, I think it is very important to look for colonization, especially for the resistant gram negatives. I think that is a very important thing, because you do two things. When you give an inappropriate antibiotic, you're not causing any benefit to the patient. You're risking toxicity, and your risk of getting an adverse morbidity and mortality. Now, how frequently do you have to do it? I don't think there is a real protocol for that. A lot of people do. Now, what else can you utilize? We have utilized that different therapies that you can do. One, we in sub-selected patients, so a couple of patients who had persistent carbapenem resistant gram-negative bacteremia, you can do selective gut decolonization in those people. To clear that, we use things like colistin, bacitracin, oral colistin to decolonize the gut. Emerging therapies, fecal transplant, not only utilizing donated stools, but now that we have microbiome-based therapy, which basically what you're populating the gut with the organisms that you want, not the organisms you don't want. I think that is going to be very important exactly when you know what the colonization is. C. diff is another thing to know. If you know the person is colonized with toxigenic C. diff, it is important because then you can look at those risk factors from colonization to infection, not give them antibiotics that have increased risk of C. diff infection. Don't give them unnecessary PPI. So I think there is a definitive role for that depending on how much resources and buy-in you have. And it's not important just to do it. What are you going to do with that? So I think if you have all that set up, that is the right thing to do for the patient.
Rightly said, sir. So we even initiated the FMT for 2 patients of ours, pre-BMT, where we kind of prepared them before the transplant for almost every week by doing the colonoscopy-based FMT only, because right now we don't have that enteric route being adopted much aesthetically, as you can understand. So, but however, what happened was, because in the peri-transplant period, because of the neutropenic fevers, the antibiotics being administered further again decolonizes the same flora, alters the flora. So the purpose of them was not much solved at that point, but yes, it gives us a very important potential area to work on.
So it's
Moving
a
on
very
in the
important thing for it's called the auto stool bank. I think Sloan Kettering had developed a protocol. We were developing the protocol, but then other medications became available. You bank the stool of the patient, and once they're ready to go after the chemotherapy antibiotics, you give them their own stool back. So that is also a technology. If you are developing something, that's something that is available to you, that is definitely can be considered.
Wonderful. So that's a very, very important piece of information, and I'm going to utilize and I'm going to think about it and steal another things from you then eventually then. The second important thing is that antimicrobial prophylaxis. So a lot of guidelines, say ECIL guidelines, the SOT guidelines, which we deal with, they work very heavily on onco guidelines, ASCO. They all work on the antimicrobial prophylaxis. Say in terms of the oncology patients and the particular set groups, and of course for the transplant. Knowing the fact that we already have crossed that ESBL bar, we have our antimicrobial resistance being going on, as you mentioned, in our antibiograms. How much you place the antimicrobial prophylaxis in that thought?
I think you have touched a very important and a very controversial topic. So if I'm understanding the question correctly, the question, I mean, usually neutropenic patients get fluoroquinolone prophylaxis, right? So the question, the way I understand it, if you know somebody's colonized with a fluoroquinolone resistant organism, has had an infection, invasive infection with the fluoroquinolone resistant organism, what prophylaxis do you continue the fluoroquinolone prophylaxis, or do you do a targeted prophylaxis against the previous? So I think we do not, the first step is, do the patients require fluoroquinolone prophylaxis? I think there is emerging data that, again, we might be treating ourselves, but on the other hand, you have to know your hospital and patient population. If you are heavily an institution that tries to manage people as an outpatient, patients come from far away to your institution, you cannot follow them that closely, then prophylaxis helps you in some way. Again, it protects you for mucositis patients, protects you against strep and other common infections, which are far more common than developing an invasive infection from a resistant organism. So there is some value to that, but chasing a tail is really not. I mean, I think then you lose one antibiotic because the risk does not go away. Then you target them with another antibiotic, then you develop invasive infection from another one. Similar thing happens in people, fluoroquinolones, people who are on SBP prophylaxis with cirrhosis and candidates for liver transplant. They develop an infection, you go back to either a fluoroquinolone prophylaxis. Sometimes it's easy to give, you can pick things like Bactrim, or you can think other oral agents that might be easy to do. But again, I think it's individualizing the care. What is their long-term thing? Is how many cycles of chemotherapy are planned? Is it their curative? Is it just the end and they don't require any more antibiotics? How far they live? What is the risk of dying? I think there are so many things. But one thing you cannot do is just put them on antibiotic that will cause more harm, intravenous antibiotic, or emerge more resistance. because you're playing the long game here, right? The long game is not only treating that infectious event, you are treating for subsequent infectious event. And if you just go guns blazing at the first infection, you're going to lose all your antibiotics, and then the treatment options will become very, very low.
True. So we have actually reached our losing end very faster. And of course, just to add on to our own brand, we are the TB endemic countries too. So
course.
the fluoroquinolones is again a challenge in using that kind of a thing. And of course, with the Bactrim comes a very handy. Another issue with the Bactrim is that the majority of the patients who are neutropenic, it is a myelotoxic. So then that becomes also a question. So a majority of our patients, so we do avoid using any kind of thing, of course, relying heavily on their IQ and our IQ. However, in the sub-selected group of patients, as you have mentioned, we do give the prophylaxis. So I'll just ask a quick one or two questions, and I think that we are exceeding the time. Coming to the diagnostic stewardship, because what I now and an entire of our community now started feeling is diagnostics only can lead to a de-escalation, because half of the time we are escalating in order to save the patient. So in terms of diagnostic stewardship, how you place procalcitonin, I mean, how much pro you are about the procalcitonin, B, these multiplex PCR, sir, and of course the nanopore and the gene sequencing, because the culture positivity rate has of course been a trouble these days.
So I think these are all very important questions. So I think it's a double-edged sword. Each test result has to be understood by why did you send that test. And a lot of times this happens. I mean, now one thing that has happened from COVID is everybody knows what a PCR is. A person walking on the street knows what a PCR is because they all want to get a PCR. And this is something that happened in our, like were very restrictive about using these multiplex PCRs. And now person walks in, our hospital, they get vancomycin, they get zosyn, they get a respiratory multiplex PCR, and they get all the other things. And what do you do with that test result is very different. So I think that is one thing. So you have to. So our thing about diagnostic stewardship is to make sure we're sending the right test for the right patient. Because if we're sending an inappropriate test, just like we send an inappropriate antibiotic, the risk is the other fold. You basically at higher risk of increasing the utilization of antibiotics. But remember, it adds to the anxiety. Now you have a positive test. I have to do something about that test. So unless you have a setup where somebody's going to actually review the test and give feedback to the providers, it can be a double-edged sword in some ways. We utilize for procalcitonin, we started using quite a bit, but I think I have leaned away quite a bit from those things. Immunocompromised patients, if you suspect an infection, our focus is give antibiotics, but then have a plan to stop and de-escalate rather than rely on procalcitonins. The only time we rely on procalcitonins is when my pretest probability of a non-infectious syndrome is pretty high. The person's coming in, I can use it as an adjunctive agent. Only to, so I have a patient with congestive heart failure, comes in, abnormal looking chest x-ray, and then you do a respiratory multiplex PCR on top of that, it is positive for a virus. Fine, it's positive for influenza, you treat influenza. Now there are providers who say, what if it's a bacterial infection? Right? So you have one alternate diagnosis, you have two alternate diagnoses, then you can layer procalcitonin on top of that to try and ease the fear of the providers that, see, we have alternative diagnosis, don't use that. And the other scenario we have used it is to decide the duration of therapy. Person's doing extremely well. You had the source, you did the source control, they're ready to go home. There are no oral options. The choice is to leave them in the hospital with IV therapy for X number of days. This is where getting a procalcitonin, monitoring the response, all right, there's a good response. I think the person's doing well. Again, using the test as an objective test to ease anxiety among all the providers and say, all right, I think the patient is okay for discharge. Those are the only places we have seen it. Otherwise, I find it, just my opinion, not a very useful test. The newer technologies, I think they are again extremely useful. I do not know. I mean, if you guys have metagenomics and all that stuff available in your microbiology lab, more power to you. I'm jealous. We have done it only under funding. Our microbiome does not use conventional things. So we were spoiled when we had the money to run all these things, and now we have to go back. But we do have the rapid organism identification and or identification of certain resistance pattern in the blood, so and in the urine. So that helps us escalate or de-escalate a little bit. But I think the future clearly is in genomes. I mean, nanopore is an excellent technology. You do not have to batch the samples. You can run each sample. It gives you not only what the organism is, what the resistance gene might be available. And I think the future would be you can do transcriptomics on top of that. That can help you predict what the response to the patient might be. Would that person be targeted for double therapy, single therapy, switch to oral therapy? I think that's going to be an excellent thing to do. So I think all these tests are wonderful. They help us take care of the patient. But I think what I go back to that is, why did you send the test? And you need to have a mechanism in place for the person to identify how to interpret the test and how to utilize it. And that person should have trust with all the providers. Otherwise, it leads to a lot of overuse of antibiotics also.
Very well said, sir. So we should have a pre-test probability for each and every test, I would believe. Of course, we do have multi-TOFs. We do have the multiplex PCRs. Sometimes we do get bugged because, especially as you said, the type of sample is also very important when we are running these kind of multiplex PCR. But as we say, that desperate situation, desperate needs. So many a times we have a difficulty in following up also in these tests, because as you say that the cost effectiveness is sometimes a question in majority of our patients. So again, coming to the last question, I would say that how much is the follow up cultures required? Duration you have already mentioned, but in terms of say a gram negative bacteremia, I have a positivity in the culture. The patient has to be persistent neutropenic for don't know how long. So in that scenario, do we need to have a follow-up culture bar kind of a PCR or a metagenome, because some copy number will be there?
Yeah, so I did not show that. The time was limited, but in our treatment guidelines for gram-negative bacteria, gram-positive, and for Candida bloodstream infections, we do have in the bundle, we have guidance of when to repeat blood cultures if they need to be repeated. So I think it is pretty clear cut for us for gram-negative bacteremia, unless they are having persistent fevers or they have an underlying, you worry that they might have an endovascular focus or a source is not very clearly identified. Those are the only conditions where we ask for a repeat blood culture. For gram-negative, we do not repeat blood cultures at all. For gram-positive, the only thing we require is for Staph aureus, because again, the risk and the treatment duration is slightly, for us, we have 2 weeks of therapy versus 4 weeks of therapy, and that is driven by how quickly they cleared the bacteremia, included other things, did not really include in this talk. So we do require repeat blood cultures for Staph aureus. We do require for Candida. For gram negatives, again, to summarize, when the source is not clear, then we report it. If you worry about an endovascular infection, that is the only time. Or if they're persistently symptomatic from fever or they're hypotensive, that might be the only scenarios where we repeat it. For everything else, we don't repeat gram negative blood cultures for gram negatives.
Understood. So just an extension of it, suppose the cultures are negative. Many a times we do face this situation where we have to empirically do the stuff, and the cultures are negative, much less or a difficult access to any other advanced diagnostics thing. So how to de-escalate in that scenario?
If you find the answer, tell me. No, I think that is a really tough one, right? I mean, I think, but that requires again, I rely on talking to the teams, and I think we make kind of a group decision as to what the best thing might be. Again, looking at the entire evidence of where do we think the source was, what do we think the presumed organism was, do we think this, or do we have radiology results that show that there is nothing else going on? I think if that is there, then be very quick to de-escalate and stop therapy with a shorter course. If things are not very clear, that happens in a small subset of patients, but the source is not very clear. The person came in extremely sick. Talk to the provider. Again, I think the part of the trust with the providers is that they have to feel okay with the decision making. And I think when I talk to the providers or an oncologist or a transplant surgeon, is I am learning from them as much as they're learning from me. So I think that is helpful. So we kind of make a individual decision, each patient based on the discussion between the providers rather than come with a random thing. Because what happens, the risk is if you get it wrong one time or twice, then you have to start the trust process all over again. If you're wrong, then it's a shared decision, right? So it's not all on you. I mean, you are going to be wrong. I mean, I think you have to be prepared to be wrong, but you want to put yourself in a position where you're doing the right thing for the patient, short term, long term. So I don't think there is one right thing to do. You just have to evaluate the patient in totality.
That's true, sir. So I think the customized regime still holds true, whatever the things comes by. And I agree to it because every person, every patient, every scenario is different. So just on the demand of the things, sir, one last question before I overserve. I am stopping it. So actually, we do have the sequencing access. So how is it any difference in sequencing a clinical sample directly versus sequencing a culture?
Yeah, I mean, there's huge difference. One is the timeline, right? So if you can sequence if you can sequence the blood, I mean, obviously we're talking about a sterile body fluid,
Yes.
right? So if you're talking about urine or something else, it's going to come with it. I mean, even though there's very good data for use of nanopore technology for urine for UTIs too, but the definite advantage of doing the body fluid sequencing is you get the data much quicker rather than you wait for the culture, a purified culture, and then you sequence it. So I think you definitely get there is an advantage of doing that stuff early, and that is probably the few. I mean, there is a lot of literature that is coming out of directly sequencing, mainly from the blood, for not only organism identification. I mean, there is technology for doing phenotypic testing as well now, directly from the blood. There's for genotypic testing that is available. I mean, of course, it comes at its own risk. That does not necessarily mean that is going to be the infection, but at least it helps you just make sure that while you're waiting for the traditional lab testing to come back, you're not missing out on the empiric therapy. You do the empiric therapy. So I think whatever, if the technology is available to you, more power to you. You should utilize the technology to take care of the patient. Now, do you have sequencing directly from the blood, or do you have sequencing from the pure culture that goes into the lab?
So right now at our place, of course, we don't have it. We are still outsourcing it, but sooner we're
Okay.
gonna have it on at our place also, thanks to our molecular hematologist. So in that scenario, that in that sense, sir, we usually send it directly from the blood sample,
Okay.
like something like the nanopore does, because again, the whole essence of it, that if the culture is there, the whole essence of sending it comes at the questionable cost again. So yeah.
And what's your
Or-
turnaround time usually?
So the TAT usually is 2 days, sir.
Okay.
Yeah.
I mean, usually nanopore, you can get the answer in 3 hours, 2-3 hours. That's the whole advantage. And
True.
the machine is really small. We do have a mini ion machine in our lab, but we don't have the license to use it. So it's sitting there. But I think that is going to be fascinating down the line. It's a really good time to be an ID physician.
Right, sir. So even we are getting a Genexus soon
Oh,
to
nice.
start working on this. So we already have a Genexus machine in our hospital to work on all the cancer-based genomics, but sooner it's going to be having another domain as a infectious disease. Right. So thank you so much, sir. And I'm not going to load you with further questions because it's already post 8. But thank you so much, sir, for that wonderful, wonderful talk. And of course, it opens much more avenues to research, to get interaction with people like you, the stalwarts like you, and of course, more to do, dig in the potential era of AMR. So thank you so much for your great talk, sir.
Thank you for the invitation. Thank you all. Bye-bye.
Recording stopped.
Thank you so much, Abhay, sir, for the great talk. It
Oh,
was
that's my
pleasure.
pleasure. Absolutely my pleasure. Thank you.